Good afternoon, everyone, and thank you so much for your patience this afternoon. We had some technical difficulties and we are finally ready to get started. We do have closed captioning along with ASL interpretation this morning, and we will be recording this webinar. If you have any questions, we will give you answers if you ask them through the Q&A button at the bottom of your screen. At the end of the webinar, we will have some resources for you to use should you be interested in following up. And we also have a list of references for the information provided through the webinar. We would really love your feedback. So please, there will be a feedback form, a link to a feedback form in the chat box. And we would appreciate it if you would fill out that feedback form and let us know what you found helpful and what you would like also to see in our webinars. So without any further ado, I'm going to just describe the process for closed captioning. You just touch the CC button at the bottom. And if you want to make sure, and if you need the interpreter services, you can pull over the screen using your cursor. So our speakers today are Lauren Dyer. Lauren Dyer has a BA in healthcare administration and is the mother of 2 children, ages 6 and 9. She is a member of her local parent-teacher organization, the PTO, and is also her daughter's tutor, assisting her daughter with issues with dyslexia. Dr. Heidi Leftwich is an associate professor in the Department of Obstetrics and Gynecology, Division of Maternal and Fetal Medicine at the University of Massachusetts Chan Medical School, and practices at UMass Memorial Health since 2014. She completed her OBGYN residency at the UConn and her maternal and fetal medicine fellowship at the University of Illinois Chicago. She, along with Dr. Harris, served on a roundtable for the Spina Bifida Association of Greater New England and discussed pregnancy and fertility concerns in 2021. A strong advocate for all her patients, Dr. Leftwich continues to work towards safer, more equitable, and overall improved care for pregnant patients with disabilities. Dr. John Harris is an assistant professor of obstetrics, gynecology, and reproductive sciences at McGee Women's Research Institute and the University of Pittsburgh. Dr. Harris is the director of the McGee Women's Hospital Center for Women with Disability. His clinical expertise in women's healthcare for women with mobility and intellectual disabilities. His research focuses on improving reproductive healthcare education for disabled women and how severe obesity and disability is managed through the healthcare system. He has research funding from the U.S. Agency for Healthcare Research and Quality, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, and the Pennsylvania Department of Health. Welcome to all of you, and thank you for being here today. I'm Linda Long Balil. I'm an assistant professor at UMass Chan Medical School, and I will be your facilitator. And speakers have asked me to interject as I feel it appropriate throughout the webinar, since I am also a mother with a disability. I'm going to have our speakers be the main event. So we're going to start today with Lauren's story. Lauren?
Hi, thank you for having me. I'm Lauren. I live in New Hampshire, and as Linda said, I have 2 kids, a 6-year-old and a 9-year-old. I have spina bifida, and I don't want to use the word severe, but it's not like a lot of people who have spina bifida, where I am fortunate enough to not have a shunt. I have not had bladder or bowel issues. It's mostly been neurological with as far as sensation and movement and stuff. So when I was younger, I did ambulate. I wore leg braces for a while until I was like high school and didn't want to wear them anymore. When I was away at college, I started having really bad spinal pain or back pain that forced me to leave school. And I had spinal fusion surgery when I was 20, which left me partially paralyzed. I already had weakness in my legs, but I never required the use of a wheelchair until then. I did use or I can use crutches or a walker at times. I did use crutches during my first pregnancy because we lived in a 2-floor condo. But during my second pregnancy, I just primarily used the wheelchair. So that's kind of the overview of my disability. Going into it, so I'm a big planner, and so I wanted to do everything right with it came to having children. So when my husband and I got married, actually prior to getting married, we knew we wanted to start trying to have kids soon after. So before we got married, we met with my orthopedic surgeon, who I had seen from pretty much the time I was born until through like my mid 20s. And to find out if my spine was stable enough to be able to carry a baby. My whole life, my parents were told they would ask if I could have kids, and my parents were told they don't know. And so I never really knew if I could even have kids until I actually did. So he said everything would be fine. He doesn't see any reason why I couldn't. He said my spine is solid and fused and everything's good in there. So the next step was we met with a high risk doctor at one of the top hospitals in Boston. We wanted to be in Boston just in case there were any issues, or I didn't know if there was a chance that our baby could have spina bifida, and I wanted to be close to Children's Hospital and just in the Boston area in case there was anything wrong. So we met with him, the high risk doctor, to discuss. Mainly it was because I was on a class C medication at the time, which I had been on for years. And I wanted to know, what do I do? Is there something safer I could switch to? It was, I was on baclofen for leg spasms, and the doctor determined that it's the benefit outweighed the risk and I could stay on the medication. So I did that. And then at the same time, he also prescribed me 4 milligrams of folic acid to start taking. And I started taking a prenatal too. I took the folic acid because of having spina bifida and to try and reduce any potential risk for a neurotube defect. So fast forward, I got married. We started trying to have kids. About 9 months later, I got pregnant, and I'd say it was pretty normal, I guess you could say. Even though I use a wheelchair and I have a disability, I was not treated a whole lot differently. I did have to go to another floor, to the weight management floor, to be weighed because they had a special scale that I could either roll my wheelchair onto, or I actually just stood up and was able to hold on and stand up at it while they took my weight. And so I did that throughout both pregnancies. That's how they were able to keep track of my weight. And during this time, I was put on a few different medications. I had really bad sickness, morning sickness and stuff. So I was given Zofran. I had a lot of rib pain and shoulder blade pain because of having a smaller torso. I'm only 4'10", due to the spina bifida, and I have scoliosis, that the baby was kind of squished up in my ribs and it was causing a lot of pain. So I had lidocaine patches. I was on like an over-the-counter medication for acid reflux. And yeah, but other than those things, I mean, those things are typical. But everything pretty much went well. I guess. So one of the things that I was concerned about, I wanted to give birth vaginally. I was concerned about an epidural, and I did not want to have an epidural because I've had so many. I've had probably 12 to 15 spine surgeries, and all in my lower back. And I did not, last thing I wanted was a needle going into my back. And so the doctor still said that I could possibly get one. I was against it, but I agreed to talk to anesthesia, and they took one look at my spine and said they could see the scars, and they said, no, we wouldn't even try it because there's a good possibility it wouldn't work. So I got that out of the way. I had the plan of having a natural birth. If needed, I do morphine for pain management. Ideally, I wouldn't need it. And then if I needed a C-section, I knew that I would have to be put under general anesthesia for that. And so I was hoping to avoid that. The doctor assured me there was no reason why, even though I had paralysis, that I couldn't give birth naturally. My mom had a lot of concerns that my pelvis or my hips wouldn't widen enough. She just had this worry that the baby wouldn't fit. I brought those concerns to the doctor, and she said, well, the body doesn't produce or grow a baby that it can't deliver, and that it's very rare and unlikely to ever happen to me. So as my pregnancy went along, there was difficulty with trying to get correct measurements of my belly. So I did have extra ultrasounds to check the baby's growth along with both pregnancies. They also did extra ultrasounds around the 12th week, I think it was, when you do the anatomy scan, to check for just take a closer look at the spine and just the spinal cord, to make sure there's nothing going on, like spina bifida. So that I just wanted to be prepared and know if there was something we were going to have to deal with. So everything else went great. The baby was transverse most of the pregnancy, and the doctor offered me a version, I think it's called, and I said no, I did not want that done. So they were, and then at the end too, towards the end, I started having, I had like borderline preeclampsia. I was very swollen, high blood pressure, and they were checking my urine constantly. And I was kind of always I was going to the doctors pretty frequently around the 37-week mark, because they were constantly checking my my urine and my blood, and they kept saying, just, we might call you and you might be having the baby tonight. Fortunately, that never happened. But at 38 weeks exactly, I went into labor, and we went to the hospital, and they did a quick ultrasound, saw the baby was still transverse. So I needed to then be prepped for general anesthesia to have the C-section, and that's what I did. Unfortunately, afterwards, when I came out of anesthesia, the baby was fine, everything. I've had so many surgeries that I was used to surgery, but they do the paralytic so quickly, and it's a different drug, I guess. This is what I was told by anesthesia, that it's a different drug than what they typically would give you for surgery, because they need to get you to sleep and everything so fast to minimize the amount of drugs that goes to the baby's system. So when they woke me up, I went into respiratory distress. Fortunately, I don't know how long I was in distress. They did bring my husband in with the baby in the recovery room, where I was struggling to breathe. I never ended up going out, but I credit them bringing my husband and the baby in there because I was able to focus on them. And I feel like that kind of kept me trying to breathe. And eventually, I mean, I don't know how long it was, but I eventually came out of it. And all was good. They have no idea still to this day exactly what caused it. But so eventually I was brought to a regular room. I was able to breastfeed, which I breastfed after both pregnancies, both of them for a little over a year. This the first pregnancy, I had struggled a little bit in the beginning, and we did have to do formula a little bit, but the second one exclusively breastfed. And so when we were in the postpartum room, I realized when they got me up to go to the bathroom that it was not a wheelchair accessible bathroom in my room. So because I had the wheelchair, I had to keep the door open and my husband would kind of stand guard. I mean, at the same time, I'm weak, had general anesthesia and major surgery and had a baby, and I was still very swollen from preeclampsia that I just needed. It felt like I didn't have any privacy. Like I needed my husband there to help me, but at the same time, I didn't want just anyone walking in the room while I'm in the bathroom. So that was one big problem that I didn't know I had to worry about. Then another one was when the baby would cry because they kept the baby in the room the whole time that we were there. I was not able to get her out by myself because I'm short and short-waisted, and also having like the strength to be able to like lean over to reach into the crib and get her out. So that was very defeating for someone who's tries to be so independent. I did not like having to ask for help. The second day we were there, they did bring me a different crib that was accessible, that had like a thing that you can lift up from the side, and I was able to take the baby out. It was like bed height where I was able to get her out safely, and that worked much better. Those are two big things that I wish I had known about, but I would have, at the same time, I thought the doctors and the staff would have planned for those things, knowing for the past 9 months that I've used the wheelchair and had gotten to know like my needs and stuff. Another thing with I'll get into the second pregnancy and what I did differently the second time around in a minute, but another interesting thing that I found out after having my first baby, the doctor who was on call, I did not have my regular OB do the C-section because I just went into labor. The on-call doctor did the surgery. She said the baby would not have fit. So that was something that I learned, and I thank God all the time that that the baby was transverse, because if I had tried a natural birth, obviously things would have been much, much different and possibly not as successful. So I wanted to add that in there because that was something that my mom was concerned about. I was a little concerned about, and I was reassured multiple times throughout the pregnancy that that would not happen. And that's not something that's common for people with spina bifida. I know many people with spina bifida who have given birth vaginally, no issues, but that was something that happened for me, that the baby would have got stuck. Another thing for postpartum, I was sent home with Lovenox shots because of the increased risk of a blood clot due to me using a wheelchair and not very ambulatory, and then also having had been pregnant. So I did the shots for, I don't remember how long, but it was a few months afterwards. So then I knew eventually that we wanted to have a second baby. We waited the proper time frame between the first and the second so my body could heal up and everything. And when we started thinking about the second pregnancy or having a second baby, about 6 months before, I started talking to our doctor, or to my OB. Between the two kids, my original OB had moved away, so I decided to stick with the doctor who performed my C-section and have her be my OB for the second pregnancy. So I was at the same hospital, same office, everything, just a different doctor for the whole pregnancy. So because of the respiratory distress, the preeclampsia and all that, I wanted to do everything I could possibly do differently. So I took a different prenatal. I took something a little more natural, but still a prenatal, and had everything I needed. About 6 months before, like I said, I contacted my doctor. I got started on the folic acid again because I did not want to take any chances with that. And then after getting pregnant, I still had sickness, but in the time frame between the two, there had been some research that came out that Zofran may not be safe potentially for during pregnancy. And so that kind of made my decision easy to not be willing to try or to use Zofran again. I also went off my medication, the baclofen, in between the two pregnancies. I started tapering off under a doctor's supervision, probably about a year before wanting to get pregnant, because I wanted to have that medication completely out of my system. And fortunately, I didn't end up actually needing it, and I was not having leg spasms anymore. So it all worked out. But I did not want to be on that medication anymore. So I did that. I did have a lot of stress during the pregnancy, but no real complications. They did think they saw something with my son's spine during the second pregnancy. That ended up being nothing. They thought there were possible cardiac issues with his aorta. I had I forget what test it was, a fetal heart test for him, which did not come back great. And so they did tests right after he was born. Everything was good, but we just didn't know. But despite the stress, I was still trying to do things as natural as I could, just be as healthy as I could, knowing that I was going to have general anesthesia and the C-section again, because baby wouldn't fit anyway. So there was no way I was going to try to have a vaginal birth the second time. So yeah, I did all those things differently and talked to the doctor a lot. We had a lot of discussions about stuff. And I also mentioned that I need a wheelchair accessible room with a wheelchair accessible bathroom, and that I needed that crib like available as soon as possible. Like I wanted it right away after I was when I was brought to my room that I would be in for the next few days. So I mentioned that multiple times throughout the pregnancy. At the same time, I don't think anyone enjoys doing Lovenox shots. I was a little bit traumatized and had a lot of anxiety about doing them the second time around. So I asked if I had to do it. They did not feel comfortable saying no completely. So they had me meet with the hematology department, which they ran a bunch of blood tests to just check some things. And we agreed upon, I think it was a few weeks or like a month instead of doing a few months of the Lovenox shots, which worked out great. Luckily, I did not end up with any blood clots. but just working with the doctors and really expressing all my concerns from the first pregnancy and having them understand was great. And one of the things though, that, because like I said, that we didn't know what caused the respiratory distress, and even minutes before them taking me into the operating room for my C-section, which I had at 37 weeks because they didn't want me to go to labor. The anesthesiologist still didn't know what medication they were going to give me minutes before the surgery because they were still concerned. They were worried about me having respiratory distress again, and that was pretty scary. Fortunately, everything went great. There were no issues afterward, and that was it. And I think my big takeaway with all of this is that doctors need to be very very open and really listen to their patients' needs for when they're pregnant and everything, because no one knows our bodies better than us, especially people with disabilities who I feel like people with disabilities know their bodies better than like the average person because they've gone through so much with their bodies or having to adapt and everything. And so, and I think some of the other things people shouldn't have to worry about it, like an accessible bathroom, an accessible crib for the baby. Those are things I didn't even know I needed to worry about, except like at home, I knew I needed a crib that I could easily access, but I didn't know in the hospital that that was even an option. So those are a couple things that I wish I had known, wish the doctor had mentioned, and I think that's it. So thank you for having me. And if you have any questions after, feel free to put them in the question box.
Thank you so much, Lauren. All right, so now we will move on to preconception education. Dr. Harris?
Thank you so much. Let me just get started. So, as you know, preconception counseling and education is a core element of pregnancy care. ACOG and ASRM helpfully define preconception education as addressing modifiable risk factors and providing education about healthy pregnancy with the goal of reducing risks of adverse health events for the woman, fetus, and neonate. For patients with a mobility disability or physical disability, the need for preconception education is higher, and the benefits of high-quality counseling are likely higher for the patient and her family. People with mobility disabilities are more likely to have preconception risk factors such as smoking, diabetes, asthma, lower reported health, and higher rates of lack of emotional support. Unfortunately, these same patients have more pregnancy and birth complications than the overall population. For this reason, preconception counseling and education is likely of great value. Additionally, people with mobility disabilities often have a wider set of questions about pregnancy and parenting. This may stem from a lack of experience with friends and peers with disabilities going through pregnancy, as well as implicit and explicit messages from medical providers questioning whether pregnancy is possible or safe. Next slide, please. Now, while all patients need to have traditional areas of preconception education covered, so that's things like medical, surgical, behavioral health, reviewing medications, family and genetic history, screening for immunizations and infectious diseases, there are specific and significant other areas that need to be addressed for patients with mobility disabilities. On this slide, I've listed a number of areas of preconception education. The bolded terms are either traditional areas of counseling that are of special importance, or areas that are not typically covered, but would be of great utility for people with mobility disabilities. So just to go through a few of these. So pregnancy intention. So one advice that I would give at this moment would also be for these patients to not just say, in the next year, are you interested in these things, but in the future, it might be in a year or it might be in 6 years. asking people about, their plans for pregnancy. And so basically including preconception education for a much wider swath of potential patients than just people that are, soon considering pregnancy, because often I believe in ACOG it recommends 1 year out, but I would recommend going farther out. When we're talking about genetic history and screening, I would encourage you to talk to your patients about appropriate genetic history and screening in the process and in terms of prenatal genetic screening. But also remember that there's a tendency, and it's in the reported literature, that screening is pressed or encouraged a little bit more than it is for other patients. And patients with disabilities sense this, and if they can't understand the reason why, it feels like it's a differential or a bias that is not helpful. In terms of social determinants of health screening, things like transportation are of a special importance to make sure that people can have accessible transportation. Going farther down, for intimate partner violence, you need to also discuss caregiver abuse, which can be common for people that may have either family or paid caregivers that help. For mobility function and physical accommodations, you want to ask about their current independence with ADLs and IADLs, as well as what devices people might use to help with mobility, and current relationships with someone like a physical medicine provider that can help with fit issues with their, say, wheelchair. For musculoskeletal health, you want to talk about the orthopedic differences that people have, how that might affect pregnancy, as well as contractures or spasms and current treatment for these. For skin health, you want to think about pressure injuries, whether those are current or past, and how to prevent those during pregnancy. For sensory and pain history, you want to think about pain syndromes, current treatments. And for bowel and bladder history, you want to think about surgeries. There are often people with extensive bladder surgery histories, people with their what their current bowel regimen is, and how we can modify that and make sure that it works well in pregnancy. And finally, for neurological or neurosurgical history, many patients may, like Lauren, have a history of spinal surgery. Some people have a history of intracranial surgery, and talking about things like shunts, seizures, and other medications is of great importance. Finally, preconception counseling can be intimidating into patients that have numerous differences that require individualized counseling. But I think with an attitude of humility and thoughtfulness, you can really greatly improve the experience for people with mobility disabilities that are considering or planning pregnancy. Next slide, please. So now I'm going to transition and talk about some of the ethical challenges that are going on that are common for people with mobility disabilities. Unfortunately, there are numerous examples of inequities and medical care biases for people with disabilities. So I'm just going to go over a few here. Starting before pregnancy, unfortunately, people, before they ever consider pregnancy, have been messaged either implicitly or explicitly that pregnancy may want to be discouraged for that particular person. Of course, that's not really providing people informed consent, but it's usually just a message that there's not a great communication there. And so people don't have a good understanding of it and are often feel discouraged about pregnancy. Once pregnancy starts, there may not be appropriate justice in terms of accommodations within offices. We'll talk about in a couple slides about what the American with Disabilities Act requires, but certainly we would all consider it just to provide the same access to our services regardless of people's mobility. Next, in a different direction, genetic screening and counseling is an area where there's a lot of reported differences and challenges in how that works. So there can be a few different things. As I already talked about, you can sort of over recommend genetic screening, so it should be universal, but it doesn't need to be extra highlighted for people that may or may not have extra risk factors. For people that do have risk factors for, say, inheritable conditions, the challenge is that you need to be very careful with your language because many of our patients may have this condition themselves. So when you have someone that has a life experience with it, and then you're describing that condition, you need to be very careful because if you describe it in its most, let's say, severe form, that can be seen as not well representative to the patient of what their experience was. And also, if someone has has, say, less symptoms than maybe another person with that same condition might have, we need to be sure to describe the full range of symptoms that may be available, while not making people feel like people are being dehumanized, or their story is as narrow as just a set of conditions, but of course it's a whole life lived experience. Labor and delivery is another area where we would like everyone to be trained really well to provide care for this, and people are not. Imagine, we're used to people with, say, in medicine that have like central venous access ports, for chemotherapy, other conditions. Imagine coming to a doctor's office and people not knowing how to deal with that and messing with it, or possibly making it to fail. That would be incredibly frustrating for someone receiving healthcare. In this case, these are patients that also require some specialized skills, and we need to be able to provide those well in whatever setting that they're in. And finally, people that are parenting with disabilities often have concerns about how they'll be perceived as parents. And unfortunately, there are definitely known stories about how healthcare providers, nurses, social workers may hear about a person with disabilities who's become a new parent, and sometimes report those to our state social services without maybe proper discussion about what preparations have already been made. And so these are a few of the ethical issues that we deal with. Next slide, please. Big picture, this is somewhat more of the philosophy of ethics, but the challenge with caring for people with disabilities would be balancing self-determination, or encouraging autonomy, with thinking about professional paternalism or questions of beneficence and non-maleficence. What this means is that we may think that it seems like the best option for a person might be to avoid this risk factor, or to avoid pregnancy with a certain condition. But that's our experience, and we need to make sure that we are actually more encouraging of their autonomy and understanding what their conception of a good outcome is, what their conception of avoiding a bad outcome. If we go, so like Lauren's story is a great example of how, with shared decision making, she was able to come up with a good solution for her Lovenox treatment. While we don't need to push everyone to get 3 months of postpartum Lovenox treatment, some balanced measure might be a good balance of the risks and benefits for that particular person. Finally, one of the real challenges when you're talking to people about the options is that there is limited research around disability. Because of this limited research, we'll either give people maybe overly high risk factors for certain conditions, or we may not properly provide the right risk counseling when a condition might be or a complication may be a little bit more common than we expect. So it makes these things extra challenging to provide ethical counseling. Finally, last slide for me, I just want to talk about the American with Disabilities Act. It covers the care that needs to be provided for all people with disabilities. Importantly, what you need to understand is the ADA requires us to make all available services available to all people with disabilities. They do not need to bring their own equipment, their own caregivers to be able to provide this care within our facilities. They should not have to make disproportionate efforts to receive this care. There are some limitations of this, including that we should be providing reasonable accommodations, which means that there is a considered unreasonable accommodation. An example of this may be when you have to provide care for multiple complex care plans around different disabilities at the same time. It would be reasonable to say, go ahead and pre-plan to have an ASL interpreter plus a mobility accessible room. That would be an area where it's understandable that you might tell this patient that we want to be a little bit more prepared, and we may not be able to provide both of those services at the first available contact with care. So once again, our job is to provide all care for everybody. It is a challenging thing, but with humility and with all the resources that we have in our amazing healthcare systems, it's very possible and can be very satisfying. Thanks.
Thank you, Dr. Harris. And now if we'll move on to Dr. Leftwich. And if folks who are not speaking could mute, that would be very helpful. Dr. Leftwich? We can't hear you.
I'm sorry, I was muted. So thank you so much. As Dr. Harris and Lauren have now discussed, it's important to think about pregnancy early. However, there is this difficulty when pregnancy is not really encouraged or even discussed. So this discussion of sexual health, reproduction, and fertility is very important to help patients have family planning and birth spacing and allow for some comfort with the idea of pregnancy. Again, as was mentioned, there's limited quality data and research out there on many care coordination with those with disabilities. And so you have to kind of read the literature and discuss with your patients that there's not a lot out there to guide you. And then also just this discussion on unintended pregnancy being higher in people with disabilities. And this is really probably stemming from the lack of conversations that are early and often regarding sexual relations and desires and the ability to get pregnant. Next slide. So kind of moving towards the desired pregnancy and focusing more on prenatal care and the postpartum care. The goal here is really to find comfort and skill set to better care for patients with physical disabilities who are trying to establish care in your office. And so by doing so, you need to highlight this equal and equitable care and how you can ensure that patients have access to this high quality healthcare during a pregnancy, even if it looks slightly different. And so the understanding is that you need to assess standard of care and meet standard of care, even if you have to alter a care plan. And Lauren had a great example of the fact that she was still able to be weighed during pregnancy. While it would be great to be in the office, there was a plan to do so that was hopefully close. She didn't tell how close that was, but hopefully it was at least a reasonable expectation to be able to do so to meet that standard of care. This also includes planning for transportation and physical and space concerns that were sort of discussed already, and some supportive accommodations that we'll get into in a little bit. This could be your staff reaching out to the patient to make sure that they know where they're going, that they have no accessibility issues, and that any kind of preventive support system that they could have for their first prenatal visit would be accessible. And I think a phone call just to really kind of initiate that conversation and that rapport is really helpful if possible. Next slide. So there's some qualitative studies that have helped guide some language and care concerns. And I just wanted to highlight some of the language here. And really it's to pay attention to the language that you're using, create a culture of mutual respect. And this really includes all members of your care team. So this is from the first person that answers the phone, who checks the patient in, to the nurse and the physicians, and all the people in your office, and then also documentation of the medical record. There are certain risk factors that we've discussed that can lead to preterm birth. One of the ones that's highlighted in multiple cases of physical disability would be the risk of bladder infections. And so having a conversation assessing for bladder surgeries, bladder dysfunction, and any need for self-catheterization or things that might put you at risk for bladder infections might be able to create a different care plan that helps you assess for bladder infections throughout the pregnancy. This whole kind of concept of asking questions and planning ahead, this is going to be your ability to engage the patient more and be able to kind of start early with this kind of relationship that you will be building during the entirety of the pregnancy. And so in the beginning, it's important, as Dr. Harris kind of started to allude to, is to ask people their limitations and their abilities and just try to figure out how you're going to access all levels of care in the office and meeting that standard of care, as well as the postpartum setting. And so then there are some that won't feel and experience contractions in a similar way. It's really important to engage patients who may not feel that similarly, to assess and have them be able to assess for signs of labor. And so this might be bleeding or vaginal pressure or pain, or an increase in discharge. So this might look different to different patients. And so acknowledging that and giving patients the ability to call with any different signs would be important to discuss. And then while nothing happens as we schedule it, and we know that, emergencies happen, overnight things happen, consider offering induction of labor or that cesarean delivery that would be planned to allow for transportation and the ability for anesthesia to have time to act. And again, that's always best laid plans and not always what happens. Next slide. And so then here, many specialists have opinions on how a patient should deliver. And so if they've even broached the conversation of pregnancy with a patient, many of the subspecialty teams have decided even prior to a pregnancy how a patient should deliver. And that's inclusive of this delivery planning, that these conversations that are had. And many patients have their own fears regarding mode of delivery. Lauren kind of talked about her initial thought process on how she wanted to deliver. These are conversations that can continue to be discussed throughout the prenatal visits. I just highlighted some quotes on a qualitative study that had two differing versions of desires for mode of delivery. So the first, after researching it, I decided that for me, a C-section would be better idea anyway, because if I tore, how am I going to take care of that? That's almost like a pressure sore. So that's someone who's really fearful of a vaginal delivery. And then another, I wanted to avoid a C-section. I didn't want to be laid up in bed with a C-section that would be below my level of injury, since my circulation is worse there, and it would be weeks and weeks to heal. So again, it's not, there's not a yes and no, and it's many times it's not a you cannot have one type. It is a multidisciplinary conversation, which should have the patient in the very center of that conversation and their desires and their fears. And I think if you start that conversation early, we can get people more comfortable with their care plan. Next slide. For the sake of time, I'm going to try to, keep moving on. We really did talk about the preconception already, so I'm going to move on from that. But outlining this plan of care and the location of delivery and resources available, this speaks to kind of that postpartum plan and labor delivery plan. If you were to come in at 2 a.m. and not have your own doctor, we now have the ability with electronic medical records to put a care coordination note. I alert the labor and delivery staff, and that includes the charge nurses and the head of the nursing, because they're usually the ones making the arrangements for the plans for the rooms. And we talked about the mode of delivery, including patient preference. And then Lauren did have anesthesia consultation. I can't stress enough that a prenatal appointment with anesthesia, more so that they just document it in the medical record and have something on file, because again, it might not be the person you discuss this with that's taking care of you. So having a care plan and having the medications chosen early as to what the plan will be if and when you come, at whatever time you come, that's in the chart as well. And then breastfeeding and any barriers to success. I know Lauren had successful breastfeeding, which is amazing. Some people have really strong opinions on whether they want to breast or bottle feed, but really supporting that positioning and any difficulties that people feel they might have as barriers to any kind of feeding, and even bottle feeding, which is definitely a bonding experience. To be able to have the baby at your chest, even if it's with a bottle, is really important to patients, and to not forget that is really important. And then screening for postpartum depression. Often we make a phone call at the 2-week mark because there's an increased risk. Lauren, I'd love to hear. Yes.
Oh, I just wanted to add that with breastfeeding, a big part of my decision to breastfeed, like my mom didn't breastfeed, like I didn't really know anyone who did, but was because with using a wheelchair and taking care of baby and having to wash bottles all day, I just didn't see how that was going to really be easy for me. And I was like, it's going to be much easier for me if it's successful to breastfeed. And so as someone, and then being out and about too, it was just easy to sit in my car and breastfeed instead of having to worry about bottles and the wheelchair and all that stuff. So something else to consider. I found it to be easier as someone with a disability to breastfeed than the idea of bottle feeding.
Thank you so much. That's such a valid point as well. Just each part of that and each struggle, trying to anticipate as much as you can. And I'm just throwing out some ideas, but I've learned so many more along the way. You will continue to learn along the way as well. I can move forward from this, but this is just another quote about talking about lifting and how this patient felt they needed their husband. And then the nurses were ultimately trained, but that the bed is terrifying and all of the pieces to this are terrifying. Next slide. And so here's kind of the additional considerations here. This is the nitty gritty, the stuff that Lauren talked about that really makes a difference. At the end of the day, safe, healthy mom and baby is the overarching goal. But then there are also these pieces that just make this so much of a better experience where you walk out and say, I felt heard. I felt cared for. I felt like a person. I felt more than my disability. And so these are the types of things that if we can really try to gain at least these and the conversation between them, I think that it will really go along with the patient and physician relationship. So we talked about the accessible weight scale. I know we're going over just a little bit, but I will try to move on. But I know there was access that Lauren had that wasn't in her prenatal care setting. These are the types of conversations you probably need to find out is where the closest one is. And if that is some sort of equitable care, if it's close enough that that's appropriate, or you might need to find a way to get one into your office. This whole fixed versus adjustable examination table, oftentimes a colposcopy room would have that one that does have the adjustable examination table. So even having one in the office would be really helpful and saving the room when you know that they're coming in. Fundal height assessments we talked about really should be done outside of a seated position. And so being able to transfer someone to a bed to be able to do that. And that assistance needing to be a communication with the patient. You will never move the same, like a different patient the same way. I can't stress enough that everyone wants to be moved in a different way and has had, like Lauren said, they know their body. Ask. It's humbling, it's embarrassing, but I promise you it will develop a relationship if you just ask. How are you best to move to this table? How can we help you best to do that? And I think that that goes a long way. And then ease of movement in the postpartum room, the size, the shape, the bathroom, the shower. I saw just quick conversation about the shower, but having a seated shower as well, a wheelchair accessible room, and having that be available to a patient when they deliver. The accessibility of the crib. I just wanted to have one quick point on this, that if your hospital does not seem to have this for you, if you ask your postpartum setting, usually the pediatric units or the PICU might be a place that you'd be able to borrow one of those accessible cribs. And given how much they really do help a patient feel independent in the room and are really critical for baby care, I think you need to try to ask around and hopefully don't have to have an additional purchase, but it might be worth a phone call. And then we talked a bit about breast and bottle feeding. And so in the standard of time, I'm going to keep going. Thanks. Next slide. So I just wanted to talk quickly about anticoagulation because Lauren also brought it up, and this is an evolving topic, honestly. Pregnancy alone, we know, increases the risk of blood clots, and people with mobility assisted devices theoretically have higher risk in the data as well. We know that if you were to get an injury or have a surgery, that you are at higher risk. And so that is a mobility kind of change throughout a pregnancy. And so that's known in the data. So the recommendation still for anticoagulation, both in the pregnancy and postpartum, is still a little bit unclear, although the few studies report kind of a significant increase in blood clot in those with physical disabilities from anywhere from 1.3 to 8%. Next slide. And so this great study came out just in March of 2023, a large population-based cohort study out of Canada that looked at 140,000 singleton pregnancies, of which 1.1% or almost 14,000 had a physical disability. So it's a pretty large study, and of those 2% or 270 patients used this assistive mobility device. And they found that this was the primary outcome was blood clot in the pregnancy or 6 weeks postpartum, that they had higher rates of VTE, both that and DVT in those with physical disabilities, but no increased risk of PE, probably due to numbers. And there were even higher in those requiring the assistive mobility devices. And so that had a 3% risk of blood clot. And so we know that that's probably our highest risk. And so while this is definitely a conversation and could be a talk in and of itself, so I won't belabor it, it is definitely worth discussion of anticoagulation, especially those with risk factors like having a cesarean delivery, having an assisted mobility device, and even obesity or preeclampsia, which can put you at risk for having a blood clot. So certainly any of those additional factors might lean you towards anticoagulation as well. And so just to finish up in summary, continued discussion and relationship building is probably the best to reach the goal of improved care with your patients and establish trust and comfort in the pregnancy and postpartum setting. And thank you so much. I'm happy to take questions with the rest of the team.
Okay, so we've been answering some questions in the chat as we've gone along here, but we have a question from a doula who has a client with a spinal cord injury, who uses a wheelchair and has feeling in most of her body, but cannot move her lower half or feel temperature. She also catheterizes from her belly button. The question is, what recommendations would you have to best support this woman through an unmedicated birth? They've talked about labor positions, and she thinks she'll be able to side lie with a peanut ball, sit on the edge of the bed with support, get on her hands and knees, and use a squat bar. So what are your thoughts?
So I think I will probably take that one, and anyone else can feel free to chime in, but I think there's two parts to that question really. And one is to support patient autonomy and the ability and the desire to have an unmedicated birth. And I really applaud the efforts to be able to care for that patient. I think that knowing the mobility that you already have put in that question is fantastic, because you know the differing comfortable ways to move, which will alter as the baby's head comes through the birth canal. But honestly, the ability to make those motions and those movements is really key. I think as much movement as possible tends to help with pain control. And so not just kind of sitting and standing or sitting and moving into the one position and kind of leaving you at that point. So the peanut ball is great, but that might be only a part-time kind of as the head's crowning position, really to help facilitate that movement and engagement of the fetal vertex or the fetal head. But I would be remiss if I didn't talk about the concern for spinal cord injury and the autonomic dysreflexia concern. And for those that are not aware, this is a longer conversation than we have for all of the questions, but there is kind of a really significant and can be life-threatening complication in those with spinal cord injury that typically we do recommend having an epidural in labor just to decrease that risk. So I would say, while trying to support autonomy and certainly the patient's desires, I'm hopeful that this part of the conversation has been discussed. And if not, I think really needs to be a critical piece of this decision-making process, which can include anesthesia and a high-risk OB physician, or even really just an obstetrician that is comfortable counseling on this, with, again, a game plan of what happens if and when this were to occur, in a safe way to treat the hypertension and really kind of go through that. And again, that is a much longer answer, but I couldn't help but throw in that I just hope that is a piece of this counseling as well. And if that is still the discussion and the decision, that I think you are absolutely on the right track with acknowledging positions that are appropriate and are able to be utilized in labor, because I think that those will be helpful to be able to mitigate some of the pains of labor.
Can you just quickly explain what autonomic dysreflexia is for the audience and why it's risky?
Yeah, I mean, so I think the key components here are that, pain can create a perception that can alter the way that your body is responding, and the biggest concern is this hypertension that can happen, which can cause stroke, which can cause an encephalopathy. It has multiple complications of hemorrhage and can cause death. And so I think in a kind of more basic standpoint, this is a concern if they have a pain pathway that is not blocked through an epidural can cause this. And it's even something that can happen prior to an epidural. You're not really completely devoid of this risk, honestly. And even there's some data out there even with an epidural as well. But you need kind of a care plan. I guess probably the riskiest part is really the hypertension and that goes along with it. So having a care plan to be able to attack kind of what's occurring and being on the lookout for it. There's other symptoms such as flushing. There's a lot of different symptoms that happen, but I think kind of focusing briefly on like that hypertension and being able to hit that with short acting antihypertensives quickly would be key. John, do you have any other piece to add to that? Oh,
No, John heard us.
John, you breathe?
So I see in this chat there is this follow-up, how is it treated? And you said that it's treated with anti-hypertension medications, and it has to be done on an emergency basis, basically. Is that right?
Yes, yeah, it can be really urgent.
Yeah, so it can create an urgent and life-threatening situation.
Correct.
So.
So preparedness, right? So,
Yes.
Making sure that, this is like the level 3 kind of hospital. I wouldn't probably deliver at a community hospital if at all possible, with, additional level of support and care if that's true. Yeah.
Okay. Well, thank you all very much. That's all the time we have for today. I really appreciate everyone staying late so that we could really provide all the information that we needed to provide. I hope that people found this helpful. And again, thank you all.
Perfect. Thank you so much.
Rest of your day.
Thank
Bye-bye.
you.